I am Dr. Fiji MD, Assistant Professor in Pediatrics, now working in NICU, Government Medical College, Kozhikode. So next we will go through the common etiology of neonatal seizures. As you all know, the most common cause for seizure in a newborn baby is hypoxic ischemic encephalopathy um, in our country. So this is around 50 percentage. This accounts to around 50 percentage of all neonatal seizures. Then the others are infarction or hemorrhage in the brain, infections, metabolic conditions like hypoglycemia, hypocalcemia, brain malformation, and some genetic syndromes and inborn errors of metabolism. So we will be going through the etiologies in the next few slides. First, I would like to discuss about hypoxic ischemic encephalopathy. So this can be of two types. One is perinatal asphyxia leading to a global hypoxia. Injury will be to the whole brain. And the second is a focal insult because of arterial infarct, MCA territory infarct or stroke in the perinatal period. In perinatal asphyxia, we will get some clue from the history. There will be a difficult delivery, prolonged second stage of labor, baby will not be crying after birth, may need resuscitation, and in the cord blood, pH will be low, and some features of metabolic acidosis will be there. And when we receive baby in the NICU, we can see that child is having hypotonia, respiratory distress sometimes, and may develop seizure within 12 to 24 hours. So in HIE, seizure usually occur within the first day, 12 to 24-hour period. And there will be features of encephalopathy almost always. So HIE stage 2 is characterized by seizures. We should always think that it is not the HIE alone that is causing seizure in such a baby. There can be associated hypoglycemia, hypocalcemia, or intracranial hemorrhage. So we have to uh, treat all these associated features also along with taking care of hypoxic encephalopathy. And we should look for subtle seizures and non-convulsive seizures also. There can be non-convulsive seizures detected only by EEG. So EEG monitoring is important in perinatal asphyxia cases. The prognosis depends on the severity of asphyxia. The second group is focal ischemia due to a infarct. In such baby will not be that encephalopathic as in an asphyxiated baby. Baby will be well in between and can develop focal seizures. And later in life, after 1 year or so, parents may notice some hemiparesis, dragging of feet, or early hand preference. Before that, the motor deficit of the stroke may not be evident. And some without seizure will be undiagnosed of the infarct and will be diagnosed only later in their life. This is regarding hypoxic insult to the brain causing seizure. Together, they account for around 50%. Next, I would like to tell about intracranial hemorrhage that accounts to 10 to 20% of neonatal seizure. In that, I will divide the babies into two. One is term baby, other group is preterm. In term baby, primary subarachnoid hemorrhage is a common condition where baby will be well, sucking and the tone, everything will be normal, but can develop seizure. There is only primary subarachnoid hemorrhage. What does that mean? It is not secondary to a deeper bleed in the brain. It is just a bleeding into the subarachnoid space because of rupture of small veins in the space, because of the trauma during delivery. They have a good prognosis later in the life. It will be diagnosed when we do LP. There will be blood stained CSF. Another group is deeper hemorrhages like intraparenchymal hemorrhage, subdural hemorrhage, or the parenchymal hemorrhage leaking to the subarachnoid space causing secondary subarachnoid hemorrhage. In such condition, baby will be more sick and they can have associated problems. These intracranial hemorrhage usually occur between 2 to 7 days of life, unlike HAE where hemorrhage manifests in the seizure manifests in the first day. In preterm baby, unlike these term babies, the area of bleed is in around the ventricle. Germinal matrix hemorrhage, sometimes intraventricular hemorrhage, leaking to the surrounding parenchyma. These babies usually develop intraventricular hemorrhage on the third day or so. And it manifests as generalized tonic posturing of the baby. It is not actually seizure, it is a manifestation of raised intracranial tension leading to a tonic posturing. So here EEG may look normal, may be normal, and the prognosis is not so good as in a term baby with intracranial hemorrhage. They can develop hydrocephalus and other sequelae. Spastic diplegia, etc. can occur. So we have covered the second main cause, that is intracranial hemorrhage. Third cause is metabolic causes. There are anti-metabolic derangements leading to seizure, of which hypoglycemia everybody should remember, especially the nurses, because whenever a baby develops seizure, whether it is a hypoxia patient or having intracranial hemorrhage, we should do GRBS to check whether the baby has hypoglycemia at that moment. Whenever it is less than 50, we have to treat. In the first day, it may be slightly low, less than 40. After that, around 50, below 50, we have to treat. And what is the importance of identifying these metabolic causes? It is easily reversible with minimum intervention. Unlike the global hypoxia and all, which nothing can be done immediately. Here, the nurses should pick up hypoglycemia, and you should be knowing who all are predisposed to hypoglycemia. Preterm babies, small for gestational age baby, babies of diabetic mothers, those having hemolytic disease due to incompatible blood groups, inborn errors of metabolism, and some other rare syndromes like Beckwith-Wiedemann, hyperinsulinemic states. Such babies are prone for hypoglycemia. Prevent hypoglycemia, ensure feeding or IV fluids, detect and treat hypoglycemia whenever it occurs. And usually they have some symptoms prior to seizure, that is jitteriness, loss of tone. There can be apnea as a manifestation of hypoglycemia, and later only they develop seizure. And the prognosis, long-term prognosis is not at all good. 50% of them can have sequelae if they develop hypoglycemia and seizure in the newborn period. So we should prevent hypoglycemic seizure at any cost. Second common condition is hypocalcemia. It can be divided into early hypocalcemia that occur in the first 3 days, late hypocalcemia that usually occur after 10 days. Early hypocalcemia common in perinatal asphyxia, small for gestational age babies, infant of diabetic mothers, preterm babies, etc., where we should give calcium supplements and sometimes treatment whenever we detect hypocalcemia. So ionized calcium less than 1.1 in term baby and less than 1 millimole per liter in preterm baby can be considered as hypocalcemia. Late hypocalcemia occur when there is hypoparathyroidism, Dijorge syndrome, or when the baby is on high phosphate formula feeds. Then also we have to treat. Third condition is hypomagnesemia. This is when serum magnesium is less than 1.4 milligram per deciliter. Here, one important thing all nurses should remember. If a baby has hypomagnesemia, that will affect the parathyroid gland, and the hypocalcemia also will be there, and that hypocalcemia will not get corrected unless we treat this magnesium deficiency. So refractory hypocalcemia, always think of magnesium deficiency, give magnesium, then only calcium will get corrected. Another two conditions I would like to present here is pyridoxine deficiency and many inborn errors of metabolism. Pyridoxine deficiency is a condition where a simple measure like supplementing pyridoxine can revert or stop the seizures completely. So, in idiopathic seizures or without obvious cause, if a baby develops seizure, in many NICUs, we give pyridoxine empirically and look for response. Hyponatremia is also another reason, a metabolic reason for seizures. It can occur when there is diuretic use, when there is syndrome of inappropriate ADH secretion, or conditions like CCF, preterm babies with IV fluids, or vomiting. All these can cause hyponatremic seizure. In inborn errors of metabolism, this manifests usually after 2 or 3 days of feeding. So, in the breast milk, many proteins will be there, and the protein metabolism will not be properly occurring in such babies. There can be abnormal metabolites getting accumulated and causing seizures and encephalopathy. So, the markers are initial 2 days child is normal, then develop acidosis, hypoglycemia, hyperammonemia, and encephalopathy. There can be history of consanguineous marriage and death of babies similarly in the newborn period or development delay in siblings. Then we should think of inborn errors of metabolism. I'm not going into the details of such IEMs. So this also contribute around, these metabolic causes contribute to around 20% of seizures. Fourth group is infections. In that, we can have bacterial infections of late onset sepsis, E. coli or group B streptococci causing meningitis and seizure. This usually occur after initial 3 days. But some intrauterine infections like toxoplasma, CMV, rubella, herpes, these can produce meningoencephalitis and seizure within the first day or due to this calcification or cerebral dysgenesis, because if the intrauterine infection occurred early in the pregnancy, it can affect the brain growth itself. That is known as dysgenesis. In such baby, there can be refractory seizures. This is identified by some clues. One is history of such fever in the mother. The second, intrauterine growth restriction for the baby. There can be thrombocytopenia, hepatosplenomegaly, PDA, cataract, deafness, etc. or rash in the baby. In such baby, we will suspect torch infection. Fifth group is developmental defects of the brain, in that dysgenesis, neuronal migration defects, or some neurocutaneous syndromes like Sturge-Weber syndrome, where we can see a reddish color in the face because of the skin hemangioma and seizures. Sometimes tuberous sclerosis can also produce seizures in the newborn period. The miscellaneous group, so these two account for around 1% of seizures, and the miscellaneous also around 1 to 2%. One is local anesthetic injection, accidentally injected into the scalp veins of the baby. Another important group is epilepsy syndromes. There are multiple idiopathic epilepsy syndromes, fifth day fits or benign familial neonatal seizures, and these two, the fifth day seizure and benign familial neonatal seizures, are having good prognosis. They usually have seizures after 2 to 3 days and subside by, and the fifth day seizure subside by 2 weeks and the other one by around 3 months. Both subside and the overall prognosis is very good. Unlike the epilepsy syndromes where Ohtahara syndrome or early myoclonic epilepsy, the baby will have multiple episodes of seizure refractory to drugs. There can be severe development delay and the overall prognosis is very bad. So these are the common causes of seizure. And as a summary, I would just repeat these. Main cause is hypoxic ischemic encephalopathy. Second is intracranial hemorrhage, of which term and preterm babies have two groups of hemorrhages. Third is metabolic conditions, hypoglycemia, hypocalcemia, hyponatremia, hypomagnesemia, or IEMs and pyridoxine deficiency. Fourth is infections, late onset sepsis or intrauterine infection. Fifth is cerebral dysgenesis or the malformations. Sixth is miscellaneous conditions. Thank you.